the WHO virtual press conference on COVID-19 and other global health emergencies today, Wednesday, 29 June. We have simultaneous interpretation in the 6 official UN languages: Arabic, Chinese, French, English, Spanish, and Russian, plus Portuguese and Hindi. Let me introduce to you our speakers. First of all, Dr. Tedros Adhanom Ghebreyesus, WHO Director General, Dr. Mike Ryan, Executive Director, Health Emergencies, Dr. Soumya Swaminathan, WHO Chief Scientist, Dr. Abdi Mohammed, COVID-19 Incident Manager, and we have Dr. Sose Fall, Assistant Director General for Emergency Response. We have online Dr. Mariangela Simao, Assistant Director General, Access to Medicines and Health Products, and Dr. Joachim Hombach, Senior Health Advisor in the Department of Immunization, Vaccines and Biological, and Dr. Meg Doherty, Director, Global HIV, Hepatitis and STI. Now, welcome all. Now, without further ado, I would hand over to Dr. Tedros for his opening remarks. Dr. Tedros, you have the floor.
Thank you, Fadila. Good morning, good afternoon, and good evening. Over the past week, I have met with leaders at both the Commonwealth Heads of Government meeting in Rwanda and the G7 in Germany to discuss the interconnected crises that need coordinated action. Today, I will cover health and humanitarian challenges that the world is facing, which only with concerned action by governments, international agencies, and the private sector can we solve the converging challenges. On COVID-19, driven by BA4 and BA5 in many places, cases are on the rise in 110 countries, causing overall global cases to increase by 20%, and deaths have risen in 3 of the 6 WHO regions, even as the global figure remains relatively stable. This pandemic is changing, but it's not over. We have made progress, but it's not over. Our ability to track the virus is under threat as reporting and genomic sequences are declining, meaning it's becoming harder to track Omicron and analyze future emerging variants. We're close to the midpoint of the year, which is the point at which WHO had called on all countries to vaccinate at least 70% of their population. So let's review. In the past 18 months, more than 12 billion vaccines have been distributed around the world. 75% of the world health workers and over 60s are now vaccinated. The Lancet estimates that 20 million lives have been saved because of vaccines. On the flip side, hundreds of millions of people, including tens of millions of health workers and older people in lower-income countries, remain unvaccinated, which means they're more vulnerable to future waves of the virus. While the hoarding of vaccines by rich and manufacturing countries was the major barrier to access last year, increasingly political commitment to getting vaccines out to people and challenges of disinformation have been hurdles at the national level in 2022. With only 58 countries hitting the 70% target, some have said it's not possible for low-income countries to make it. I was just in Rwanda, where second-dose vaccination rates are now above 65% and still rising, and others like Nepal and Cambodia have shown it's possible. Yet, the average rate in low-income countries is 13%. But if there is enough political will domestically, support to ensure rollouts to communities and disinformation tackled, high vaccination rates are entirely achievable. When vaccine rollouts began, WHO called for all countries to start with a layered approach targeting older people and health workers who were most at risk from the virus before moving to cover the rest of the population. Going forward, to prevent deaths and severe disease, it's important to keep the most at-risk groups up to date with vaccination. In all countries, 100% of at-risk groups should be vaccinated and boosted as soon as possible. For the general population, it also makes sense to keep strengthening that wall of immunity, which helps lessen the severity of the disease and lowers the risk of long or post-COVID condition. Even relatively mild cases are disruptive and damaging, keeping children out of school and adults from work, which causes further economic and supply chain disruption. Do I think countries should continue to vaccinate 70% of the population, starting with the most vulnerable? Yes, I do. If we don't share the fruits of science equitably, then we undercut the philosophy that all lives have equal worth. If rich countries are vaccinating children from as young as 6 months old and planning to do further rounds of vaccination, it's incomprehensible to suggest that lower-income countries should not vaccinate and boost their most at risk and then work to strengthen their own walls of immunity. On the research and development front, it's critical that there is funding for second-generation vaccines as well as tests and treatments. While honing vaccines to the evolving virus variants makes sense, I'm concerned that the pace of mutation means the world is continuing to play catch-up. Building on existing vaccines that limit severity and prevent death, developing second-generation vaccines that stop or at least lower infection would be a major step forward. And the ideal solution would be the development of a pan-coronavirus vaccine that covers all the variants so far and potentially future ones. This is feasible. WHO continues to convene scientists and researchers, and there has been a lot of research into this virus and understanding immunology overall. With WHO solidarity trials, we can also offer global trials of vaccines to establish the safety and efficacy of quickly and effectively. So going forward, the world should target 100% vaccination of older people and health workers, as well as strengthening the wall of immunity against COVID-19 towards and beyond 70%. As I said at the turn of the year, tests, new treatments like antivirals should also be available in every country. Now is the time for ministries of health to integrate tests and antivirals into clinical care so that people that are sick can be treated quickly. With new variants of concern likely, genomic sequencing remains critical. I also call for accelerated efforts and incentives to be developed around the moonshot of developing a pan-coronavirus vaccine. On monkeypox, while the emergency committee did not advise that the current outbreak represents a public health emergency of international concern, they acknowledged the emergency nature of the event and that controlling the further spread requires intense response efforts. They also advised that I should reconvene them quickly based on the evolving situation, which I will do. Nigeria, which has been battling an outbreak since 2017, has reported more cases this year, which could mean it matches or exceeds previous peaks. Furthermore, the virus has now been identified in more than 50 new countries, and that trend is likely to continue. I'm concerned about sustained transmission because it would suggest that the virus is establishing itself and it could move into high-risk groups, including children, the immunocompromised, and pregnant women. We're starting to see this with several children already infected. Right now, this is the action WHO would like to see. 1, countries should increase surveillance by boost testing as quickly as possible. 2, countries should take a best practice approach to managing the response. WHO has already published clinical guidance to assist public health agencies and health workers on the front lines of this outbreak. 3, actively engage communities. With large gatherings happening around the world, there are opportunities to both squash the stigma around the virus and spread good information so people can protect themselves. WHO is actively working with LGBTIQ+ communities to do just that, and we encourage groups to get in touch with us if we can support. 4, ensure that we provide equitable access to countermeasures like vaccines and antivirals, and also ensure the systematic collection of clinical data and efficacy to inform future recommendations. WHO has been convening scientists via the R&D blueprint for epidemics to speed up research and development into tests, treatments, and vaccines for monkeypox, and develop a protocol for therapeutic development and rollout. The food crisis across the globe, spiking prices of not only food, but fuel and other commodities, are leading to millions of people missing meals and going hungry. This is having major physical and mental health repercussions. People need access to affordable and nutritious food, as well as support through these difficult times. Some regions, like the Horn of Africa, are facing extremely serious food insecurity issues that could lead to famine. Over 80 million people, 1 in 4, in the Eastern Africa region are food insecure and resorting to desperate measures in order to feed themselves and their families. Lack of food and nutrition weakens people's immune system and puts them more at risk of disease. Children that are undernourished are at higher risk of death from pneumonia, diarrheal disease, and measles. As I said at the G7, WHO is working with partners on the ground to respond to this health and nutrition crisis. This includes getting essential health services to those in need, treating sick children with severe malnutrition, and preventing, detecting, and responding to infectious disease outbreaks. WHO is setting up a hub in Nairobi from where it will coordinate the response and organize the delivery of life-saving medical supplies to where they are needed most. These supplies include medicines, vaccines, as well as products and equipment to treat children who are severely malnourished. WHO is working with the Ministries of Health in Djibouti, Ethiopia, Kenya, Somalia, South Sudan, Sudan, and Uganda to set up robust disease surveillance system to be able to quickly detect and respond to disease outbreaks. Finally, in light of the decision by the US Supreme Court overturning the Roe v. Wade, I want to reaffirm WHO's position. All women should have the right to choose when it comes to their bodies and health. Full stop. Safe abortion is health care. It saves lives. Restricting it drives women and girls towards unsafe abortions, resulting in complications, even death. The evidence is irrefutable. Limiting access to safe abortion costs lives and has a major impact, particularly on women from the poorest and most marginalized communities. Over the last 40 years, the global trend is toward women having greater access to safe abortion, and while last week was a setback, it's important than ever to come together to protect women's right to safe abortion everywhere. I thank you. And Fadila, back to you.
Thank you, Dr. Tedros. I would like also to welcome Dr. Bruce Ellward, who joined us in the room. Dr. Ellward is the Senior Advisor to the Director General, and he leads also the ACT Accelerator work. I will now open the floor to questions from members of the media. I remind you that you need to raise your hand using the raise your hand function in order to get in the queue to ask your questions. Let me see who us. I think that I think that we have Helen Branswell from STAT. Helen, you have the floor for the first question.
Thank you very much, Fadela. I'm wondering what WHO is doing to try to see if there are ways to increase production of monkeypox vaccine globally. I believe the Bavarian Nordic line is currently down. Is there anyone else who could step in to make their vaccine? Could another line be repurposed? And I would also like Dr. Tedros's thoughts about the fact that supplies of monkeypox vaccine are limited worldwide and held in very unequitable ways. The United States has most of the vaccine, I believe. What is being done to try to address that, please?
Thank you, Helen. Dr. Ryan?
I can begin. Sumir Associate Abdi may wish to supplement. I think, first of all, I think the good news on this is that the countries who have been stockpiling vaccine, and remember, in this case, the vaccines that have been made and stockpiled have been stockpiled for the purposes of a potential response to a smallpox outbreak. In fact, the vaccine itself is not smallpox and it's not monkeypox, it's a vaccinia virus vaccine. And the countries that have currently stockpiled that vaccine, including the US and led by the US, have expressed willingness to share those vaccine products with other countries. But again, we must remember that these products have been licensed in the main for the use in smallpox. In one case, they've been licensed for monkeypox, but again, based on animal models and based on, I believe, immunobridging data from the smallpox side of things. So it's really important as we encourage the sharing of these products that we also collect the necessary clinical efficacy data so that we continue to gather data. As we did, many of you would have followed, and you especially, Helen, would have followed the experience of Ebola in Congo and how we used the opportunity of being able to formally expand the use of Ebola vaccines while collecting critical data, do randomized or controlled clinical trials on the use of the antivirals, in that case, and monoclonal antibodies. So in this case, we would like to see that same process, and already the Research and Development Blueprint for Epidemics group have convened meetings on that. Some of you may speak more to that. We are also exploring the possibility of being able to distribute those products. Again, WHO would only be in a position to distribute those products really if they were part of that enhanced data collection. Because again, these are not licensed products that you can go and procure on the shelf and then send to countries. The national regulatory authorities in countries, national ethical authorities would have to look at the use of this vaccine, the risks versus the benefit of vaccines, and then we would hope introduce those vaccines as part of a public health response while collecting the necessary data. We stand ready to pull together the necessary protocols to support the development of such protocols and ultimately to facilitate the distribution of those products to countries. But just to be clear, those countries who do currently hold product are actually very willing to share that product and have indicated that willingness to WHO, and we thank them for that. Again, emphasizing once more that the primary intervention is reducing transmission by intervention, by education, by avoidance of infection, and then using vaccines and antivirals in a targeted way. And at the moment, vaccines are limited in their use really to health workers at high risk, to defined contacts of cases, and in some cases, in some countries, countries are beginning to look at the idea of high-risk individuals who may not be contacts but are engaged in high-risk activities or are at particular risk of being exposed, and are offering that vaccine to those individuals. I don't know if anyone else wishes to supplement.
Thank you, Dr. Ryan. I would like now to invite Isabel Sacco from FA to ask the next question. Isabel, you have the floor.
Hello, good afternoon. On monkeypox, I would like to ask on the comments by the DG of cases among children. I would like to know how many cases have you recorded, in what countries, how these children have got infected, and if there has been any severe cases of monkeypox among children, or all cases have been mild cases. Thank you.
Thank you. Dr. Mahmoud?
Thank you. Just to give an update, as DG has said, the main things why we intervene, we are worried about monkeypox going to vulnerable population like children, like pregnant women. That's a major population of concerns for us, and we are working very closely with all our member states. So far, there have been a number of cases reported, particularly countries with good surveillance. We are aware about 2 cases in UK, and we are following up with Spain and France. And when we say children, children are less than age of 18. Some of them may be male of 17, 18. We'll share. So as of now, we don't have any severe cases, but it's an age group that we are really concerned about, as DG has said. So overall, it has been mild, but if it spills over to this population, it's kind of that. So we have to do everything possible with the public health proven measures to control this pandemic outbreak that's going on among these high-risk groups.
Thank you. I would like now to invite Denise Roland from Wall Street Journal to ask the next question. Denise, you have the floor.
Hi, thanks for this. I wondered if you could talk us through the specifics of why the advisory committee concluded that monkeypox is not a public health emergency of international concern. On the face of it, it seems to meet the criteria, so I'm just curious about what was the case against declaring it a fake?
Dr. Ryan?
I think the committee actually submitted a really detailed report outlining very specifically the reasons why they were concerned and why they regarded the event as something that needed intense response, that needed to be followed. And they did have concerns that while the data as presented to them did not, in their minds, reach the level of a public health emergency of international concern under the specific terms of the IHR, it still was something that required further data collection, intense response, engagement with communities, development of countermeasures, and actually they specifically, I believe, asked you, Dr. Tedros, through the report to reconvene them as soon as possible as further data emerged. So I think the calling of the committee itself was a very significant event. The committee's report clearly indicates the areas in which we need to intensify the response. They did not at that moment, and I think I do recall the committee talking about not a fake yet. They were very, very clearly saw this as an urgent public health issue that required collective response, but that it didn't quite meet, in their view, the criteria of being a public health emergency of international concern, and which is the highest level of alert that the Director General can issue. The Director General himself has accepted that assessment, but again has reaffirmed today that he will reconvene the committee as soon as other data emerges. And the committee themselves laid out some very specific requirements, or not requirements, but very specific areas in which they wanted to see further data, and WHO is working with their member states and scientific institutes around the world to collect that data. So I think we are in that moment where we need to maintain absolute vigilance regarding this disease. We need to, as Abdi has said, ensure that we can not see this disease pass into multiple sectors of the population. We have to support, and very, very much have to support, our brothers and sisters in the communities that have been most affected with this, because from our perspective, supporting the prevention of transmission and onward transmission, while supporting and celebrating the festivals and gatherings that we see that are so important in the cultural life of this planet and in the well-being and affirmation of our inclusivity as a human culture. Really, really important events occurring over the coming weeks, but we also want to encourage that they occur in the best possible way in terms of reducing risk of any further onward transmission of the disease. So we are tracking the data very carefully. We're looking for any particular increases in cases. We're looking at sequencing. We're looking at the different groups who are being affected, and we're looking for any changes that might indicate that the committee needs to be brought back together by the Director General, which he will do if there is any sign that that needs to be done.
Dr. Tedros?
No, thank you. I think Mike had explained it really nicely, but just wanted to add some more points. The emergency committee, during its meeting, has expressed its concern, and its deliberations were very, very, in-depth. And I think they have tried to understand the whole situation. And maybe one thing I would like to add to that is, because there are many things now in the media going on saying why it should not be declared. Although the members of the emergency committee don't vote, they don't vote to decide, but they do a kind of tour de table to see what the position of each individual member of the emergency committee is. And there were 14 committee members, and 11 said this doesn't qualify for now, we don't need to declare FIC for now, while 3 said the criteria is met, so we should go ahead with the with FIC, and they were in favor of FIC. So the overwhelming majority, 11, said, let's give it some time. They didn't even say, okay, it's over, we cannot declare FIC, so case closed. They didn't say that. Although they're the majority, 11 of them, they, in addition, recommended that, we ask the DG to reconvene us. They asked me to reconvene them as soon as possible. Of course, as Mike said, based on the data or on the epidemiological situation. So I'd be happy to reconvene them as soon as possible. We're tracking the situation very critically and closely, but in the spirit of transparency, I would like to also share, although we don't call it voting, the pattern of the, support, if you like, to FIC and no FIC. So that was the 11 to 3. And we're concerned as well, and I believe that their recommendation is a very balanced one. Okay, we're concerned, it looks like this now, and 11 are saying we have to wait a bit until we get more epidemiological information. And then they didn't stop there, they said, please reconvene us as soon as we have additional information. So we will discuss, we will continue to track the condition closely and reconvene the emergency committee as soon as possible and see if there is any difference to change the original recommendation from the emergency committee. Just would like to add that.
Thank you, Dr. Tedros. Dr. Sosefal would like to add something.
Thank you, Fadela. Just to add a few words on to what Gigi and Mike said already. Not declaring a FIC does not mean it's not an emergency. It's already a grade 3 multi-country, multi-region emergency, and we'll continue assessing the risk based on new information. It's already, assessed at the risk assessed at high in Europe and moderate in other regions. And it's really important to make sure that we continue managing as an emergency. You have an incident management system at global level, but in every 6 region of the 6 regions. So we continue working, managing as an emergency and making sure that we can work to stop further transmission. So it's really important to not, link the FIC with global emergencies. Already a global emergency, multi-country emergency, and multi-regional emergency. Thank you.
Thank you. I would like now to invite Robin Millar from Agence France Presse to ask the next question. Robin, you have the floor.
Thank you. On the prospect of a pan-coronavirus vaccine, how close are we to developing such a vaccine and also developing vaccines that better prevent against transmission? And if I can, how soon might the Emergency Committee on monkeypox reconvene? Thank you.
Dr. Swaminathan?
So yes, thank you for that question. It's still very much in the early stages of R&D, the pan-coronavirus vaccine. We did convene several meetings of the R&D blueprint for epidemics, networks of scientists and researchers, including the private sector. And we were encouraged by the progress that has been made, actually, even over the last 12 months, especially the progress in understanding the immune response and also what happens when you combine different antigenic elements. I mean, that's really the challenging part, is to capture the immunoreactive elements of the coronaviruses from a different, from a variety of different viruses, and try and put them all into one vaccine. We're seeing now with mRNA vaccines that we're able to develop these bivalent and potentially multivalent vaccines, not just using bits of the coronavirus, but even from different viruses. So a vaccine, for example, that will cover influenza and coronavirus, or influenza, RSV, and coronavirus. So I think the scientists feel that this is feasible, that it's doable. Obviously, it takes a little bit of time to move from the laboratory into the clinic. But I think we've also learned so much about how to accelerate clinical trials. And the regulators have been so proactive during the pandemic that we think that it's possible in a period of the next 2 to 3 years to make very significant advances here. But obviously this requires a lot of coordination, collaboration, which is what the WHO has been trying to provide the platform for. And as the Director General mentioned, we even have the Solidarity Trial that was initially set up for therapeutics, but then also for vaccines, which provides a platform to do multi-country studies of different products and try to capture the data in an efficient and timely manner. And the second part of your question is about the vaccines to reduce transmission. And again, we hope that some of the mucosal vaccines that are under development, and there are several different mucosal vaccines under development, nasal drops, inhalation, sprays from different companies around the world. And again, the Solidarity Trial has opened now to test some of these nasal vaccines. They're being considered by the Prioritization Committee. So I hope in the coming weeks that we will be able to provide an update for you. And the companies are also running their own trials. And it's possible that a combination of an intramuscular vaccine and a nasal or a mucosal vaccine might provide much better efficacy against reducing transmission or blocking transmission, as well as preventing severe disease. Thank you.
Yes, Dr. Ryan?
I just want to add, I absolutely agree with everything that Samia said, but also to emphasize that what we do have right now are superb vaccines that we're underutilizing, and particularly underutilizing in low-income countries and amongst some of the most vulnerable people in the world. They're remarkably effective. And in the history of vaccine development, to have vaccines this effective within a couple of years of discovery of diseases is unprecedented. And it's also, as we see the emergence of potential booster doses using variant strains, I think what's really, really important is that it's clear to the TAG-COVAC and other scientific groups that primary vaccination with ancestral strains, the vaccines that are being distributed around the world, particularly by COVAX, are still going to be the central vaccines to prime individuals around the world. That is the best strategy that we have. It may be over time that countries and nations may introduce booster doses using variant-specific vaccines. And then, as Samia said, we may move into true second-generation vaccines where we have pan-coronavirus vaccine. And equally, as she said, with injectable vaccines versus oral or nasal vaccines. And I think we have both Bruce here and Abdi, who come from backgrounds from the polio program, and that's exactly how polio is being eradicated, with the combination use of injectable polio vaccine, which prevents paralysis, and oral polio vaccine, which actually shuts down transmission much more effectively. In fact, I think injectable polio vaccine has little effect on transmission of the virus. So here, over many years, polio had to develop that dual strategy. That may become, as Samia said, the strategy that may be required to get full control of this virus. So I think the prospects going forward are excellent, and we should thank our scientists today and celebrate the fact that science is presenting so many innovations. It's really down to how those innovations are distributed, how they're used, how they're absorbed into systems, and how equitably those countermeasures are ultimately shared around the world. That's where we always tend to fail. I think we're getting an A+ for innovation, and we're getting an F for fairness, and that's been the story of this pandemic.
Dr. Swaminathan?
Actually, I just wanted to come back to something that Helen asked, which I think we didn't address, and that was about technology transfer. And I think that it's a very good question, because the reason that the WHO set up this technology transfer program, of course, starting with mRNA, but the goal was always to move to other technologies. And we have an amazing network now of about 15 or 16 manufacturers around the world who are working together on developing new generation mRNA vaccines for COVID, but also already collaborating and looking at developing vaccines for other diseases. So this would be a really good opportunity for people who have the technology to develop a vaccine for monkeypox, or it could be the existing Bavarian Nordic MVA vaccine, for example, to work with WHO, to work with the technology transfer program and with CTAP, so that we can actually enhance manufacturing, because it's possible that this platform could also be very useful, to develop viral vaccines in the future. So we would actually welcome conversation with Bavarian Nordic, but also with other manufacturers or other groups who have technology for orthopox virus vaccines, and see whether we can actually build that into our technology transfer programs. So thank you, Helen, for that idea.
Thank you, Dr. Swaminathan. I would like now to invite Ari Daniel from NPR National Public Radio to ask the next question. Ari, you have the floor.
Yes, hi there. Thanks for taking my question. This is with respect to the DG's comments around the reversal of or the overturning of Roe v. Wade. I was wondering whether anyone might be able to comment in particular about any impacts that decision has, or ripple effects in lower income countries or other parts of the world, or any specific recommendations or anything regarding action that's being looked into.
I can start, and I'm sure others would want to come in. The DG has already made it very clear what the WHO's position is. It's based on data, and it's based on years of collecting evidence from around the world. And I know from my own experience working in India that having access abortion is a life-saving measure. I mean, it's like denying someone a life-saving drug when you know that that can save their life. And what these bans do, or the lack of access does, is not reduce the number of abortions that take place, because if a woman has to have an abortion for whatever reason, she's going to try and get one. And therefore, what it does is drive women into the hands of people who are there to exploit the situation, performing unsafe abortions, and very often resulting in a huge amount of health damage to the health, and also sometimes death, because as you know, it can easily get infected, you can get sepsis and die. So and of course, the people who are most impacted by this are always the poorest, who do not have access to travel a long distance to access treatment, for example. And therefore, it's access to safe abortion, as I said, is an access to a life-saving, in this case, it's a procedure. It's not a drug. And there are many, many situations where this is needed, it's indicated. And in fact, in many countries around the world, a large part of maternal mortality can be attributed to having unsafe abortions. And it's unfortunate. I mean, I think overall, as the DG said, we have seen progress in this area. More and more countries are actually adopting policies to enable women to have safe abortions. In Latin America, we've seen a huge amount of progress over the last couple of years. So it's unfortunate to see some countries actually going backwards, and we will see the impact. There is no doubt that you will start seeing increases in mortality as well as in huge amounts of morbidity as a result of this decision.
Yeah, thank you. No, this is a very important question. So, there is something that I think the world should understand. When it comes to this issue, we really simplify it by saying this is like a choice about a choice a woman makes. Of course, that's there. But behind it, we have to understand that this is about the life of the mother. And that's why, as Soumya said, if safe abortion is illegal, then women will definitely resort into unsafe ways of doing it. And that means it could cost them their life. So that's one. And we have research, and this is documented, and we're not saying something hypothetical, but something documented and irrefutable. So it risks the lives of mothers. And the other impact of this decision is its global dimension. I know many have been following the decision, and it will have impact globally, especially many countries may not really understand and may follow suit, because there are many activists who are against women's rights or against women's choices. So the global impact is also a concern. And we're really concerned. This is many years backwards, and we haven't really expected that this would come from the U.S. We had hoped that U.S. would actually lead on this issue. Then the recommendations, going forward, I think one recommendation would be if the U.S. could look at this anyone who is relevant or can have influence in this to take it seriously. While to the rest of the world, I think it's very important to see it from the perspective of this is not really about a choice for women, but it's their life, and it has to be taken as such. I wonder even when this category which says pro-choice and pro-life, you know, for many women, it's not a choice they do that. It's their life. And that has to be understood when we make decisions. Not just the rights issue only. Women should have the right, but at the same time, it's about their life. Many I know from the country I come from and other places, it's when they don't have choices, and when it's about their life that they have to do it. So it's about the mother's life, and it has to be taken as such. Thank you. And Fadila, back to you.
Thank you, Dr. Tedros. I would like now to invite the next journalist, Carmen Paun from Politico, to ask the next question. Carmen, you have the floor.
Thank you so much, Fadela. I just wanted to go back to the issue of monkeypox potentially getting into more vulnerable populations like children and pregnant women. And I wanted to get a clarification on the vaccines that we have. Obviously, as Dr. Ryan was saying earlier, you know, most of them are approved for smallpox in most parts of the world. If the virus does start spreading into pregnant women and children, would we be able to use, you know, the vaccine that is approved for monkeypox in the US, for example, in these populations, or will there have to be studies? Because typically vaccines are not tested on pregnant women. So I'm wondering if, you know, how it would work in this case if we do start seeing more and more cases into those populations. Thank you.
Again, for some of the licensing for some of the vaccines and some of the antivirals, in fact, it's specified within the, even for those that are have a provisional license, it is specified within those that data collection and these be done as much as part of studies in which data will be collected in order to advance knowledge on efficacy and safety. And safety is an overriding concern. The third generation vaccines that have been developed for smallpox have been specifically developed to be less, to be more safe and to retain efficacy and to have higher and better safety profiles. And in that sense, yes, those vaccines could be used in those populations. But again, they would have to be used under supervision, under some form of expanded access or clinical study in which these could be monitored closely. These vaccines are not the same as like we would have experienced with COVID vaccines. They're not. We would have to exercise a higher level of caution, and that's why we have to balance the absolute risk in terms of severity of infection, the likelihood of spread, and then being able to use the vaccines. For example, the vaccines can be used for long-term prevention in terms of maybe vaccinating a health worker or a laboratory worker, or can be used as post-exposure vaccination in which you try to reduce the chances of a full-blown infection by giving someone the vaccine after they've been exposed. But when you do that, you have to do that very quickly after exposure. And there's a time window in which you will get some efficacy for that. So there are multiple modes in which the vaccines can be used. And therefore, for example, if you were dealing with pregnant women, you may not want to preemptively vaccinate pregnant women. But if a pregnant woman had been exposed to the virus, in that situation, you could determine that a vaccine may be useful, the risk versus the benefit. And this is, I think, Sumi, I've heard you speak about this so many times. It's about assessing risk versus benefit, and national regulatory authorities have to be able to do that in each and every case. WHO can advise them, we can provide the data, we can provide the science, but national regulatory authorities must be able to look at the risk versus the benefits. And that's why we're really asking researchers and countries and regulators to come together and come up with common standard protocols for the use of these antivirals and for the use of vaccines, so that we can use them in the safest possible way should it be needed, and that we can collect the data needed to ensure that we advance our scientific knowledge on efficacy and on safety. So yes, there are issues here that we do need to be careful in the rollout and use of these products, particularly in vulnerable subpopulations.
Thank you, Dr. Ryan. Dr. Swaminathan would like to add something?
No, just to add again, completely agreeing with what Mike has just said, we have to remember also that it's the immunocompromised people who are at highest risk of death. And if you look at people who have died from monkeypox and analyze, many of them have underlying immunosuppression, particularly in the deaths that have occurred in Africa in the past. And so we need to make the vaccine that is available from Bavarian Nordic is a non-replicating vaccine, and therefore it's safe to use in people with HIV, for example. Again, the studies in pregnancy, I think there's not a lot of data, so all of these would have to be done under protocols. And as Dr. Ryan said, I think the risk-benefit is a very important aspect to look at. But clearly, there's a huge need to collect good data. And so rather than going into mass vaccination programs at this point, which we're not recommending, it's really to do very careful studies of the vaccine in different population groups, make sure that African populations, the countries where this is endemic, are actually included in these studies so that we get data that's broadly applicable to populations around the world, and also to ensure that children, pregnant women, and the immunosuppressed are considered for inclusion in these trials.
Thank you, Dr. Swaminathan. I think that we are coming to the end of our press conference. Please do not hesitate to contact us if you have any follow-up questions. I would like now to invite Dr. Tedros for a final comment. Over to you, Dr. Tedros.
Thank you, Fadila, and thank you to the members of the press for joining us today, and see you next time.